Hello, my name is Tori Nakua. I'm a nursing practitioner student, and today I will be performing a cardiovascular exam. First, we'll start by describing important landmarks on myself for the cardiovascular exam. The first point is the aortic point on the second intercostal space on the right sternal border. This is where you can hear S2 the best. Then we'll move across to the pulmonic on the second intercostal space on the left sternal border. This is where you can hear a split S2 the best, and the only sound that may normally vary with inspiration. And we'll go down to the Erb's point in the third intercostal space on the left sternal border. Next is the tricuspid in the fourth intercostal space on the left sternal border. This is where you can hear the split S1 the best here. Then we'll have the mitral, which is the fifth intercostal space, mid-clavicular line. This is the apex of the heart, and S1 is heard the best here. Also, if you're lying on the left lateral decubitus position, you may hear an S3, S4, or mitral valve prolapse best at this point. Next, you'll have the epigastric area, which is below the xiphoid process, a little to the left of the midline. This is where you can feel pulsations if they have any heart hypertrophy. And then also the mitral regurgitation, murmur, and aortic stenosis are heard best during systole. Hi, we're back to complete the cardiovascular examination. Is that okay with you?
Yes.
And may I have your name?
Jay Nakua.
Okay. If any time you feel any pain or discomfort, please let me know.
Okay.
First, I'll start by describing the squat test and Valsalva maneuver. The squat test starts with listening to the mitral area and having the patient stand and still listening to the mitral area squatting down. If the click resolves, this may be due to a mitral valve prolapse. If the click increases, it may be due to the opening snap of the aortic stenosis. With the Valsalva maneuver, you'll have the patient lying supine and again listening to the mitral area and putting your hand on the abdominal area and having the patient bear down. If the clicking increases when the patient bears down, this may be due to a mitral valve prolapse. If it resolves or decreases, this may be due to aortic stenosis. Next, my patient's keeping his shirt on for privacy purposes, but typically with the examination, you'll do bare skin. We'll start with inspection, so I'll have him lie down. I'm looking at the pericardium while he's lying supine, looking for any pulsations, heaves, anything like that. Lifts, none are noted upon inspection. And then we'll move on to palpation of the pericardial areas. For heaves and lifts, I used my pads and my fingertips to palpate. I'll be applying a little bit of pressure. No heaves or lifts noted upon palpation. Then to assess for thrill with palpation, I'll be using the palm or the ball of my hand, applying more pressure. No thrills or pulsations noted upon palpation. Then we'll be doing the apical impulse. This is the point of maximal impulse, and is when the patient is lying supine in the fifth intercostal space midclavicular area. You're assessing the pulsation. For this, you want it to be less than 2.5 centimeters wide, a brisk, and it should be less than 2/3 of the systole. If the apical impulse is laterally displaced, this may be due to enlarged heart, and if it is hyperkinetic, this may be due to recent exercise, young age, hyperthyroidism, anemia, aortic stenosis, and aortic regurgitation. Then I'll be doing auscultation of the 5 pericardial points. I'll listen while the patient is supine. I'll be using the diaphragm. Then I'll be using the bell to listen to the 5 pericardial areas again. Okay, next I'll have my patient placed in the left lateral decubitus position. If you could please lay on your left side with your knees slightly bent. And I will listen to the 5 pericardial areas again with my diaphragm. And then I'll use my bell to listen to the area, all 5 areas again. Okay, next I'm going to have my patient sit up. Okay, and you're going to lean slightly forward, and I'm going to use my diaphragm first again. And when I'm listening, you're going to hold your exhale, okay?
Okay.
Let me know if you need to take a breath or something. Then I'll be using my bell to listen to the 5 areas again. Oh, yes, thank you. Hold on exhale. Awesome. Upon auscultation, S1 and S2 is heard. No S3 or S2 heard. No murmurs, no rubs, no gallops. Now I'm going to auscultate the arteries for any possible bruise. I'm going to have you lie again, supine 30 degrees. I'll be using the bell of my stethoscope. And I'm going to start with the carotid arteries. I'm just going to have you hold your breath as I'm listening, and then I'll let you breathe when we go to the other side. Okay, ready? Yep, hold breath. Sorry. Okay, good. No bruise heard in the carotid arteries. Then I'm moving down to the aortic, abdominal aorta. So that is below the xiphoid process and in between the umbilicus. No bruise heard in the abdominal aorta. Then I'm going to move slightly down, midline, laterally midline, to listen to the renal arteries. Okay, and then we'll be no bruise heard in the renal arteries. Then we'll be going to the iliac arteries. This is below the umbilicus, lateral in the midline. No bruise noted. Next we'll be doing the femoral arteries. This is in between the superior iliac spine and the pubic sphenosis in the groin area. I'm using the bell for all of these. No bruise heard in the femoral arteries. That will complete my cardiovascular exam. Thank you for your assistance.
You're welcome.